Okay, class, so this is going to be the lecture on multiple sclerosis. I'm going to try to get through this. I told you this was going to be live today, but I have some extra time this morning, so I'm going to try to get it recorded so you can have it to play on your own. Share my screen. Okay, multiple sclerosis, also known as MS. Multiple sclerosis is it's a chronic disease, and it's a progressive demyelinating autoimmune disease of the central nervous system. So it is a disease that demyelinates the nerves of the brain and part of the spinal cord too sometimes. If you do scans, if you do MRIs or CTs, you can see widespread lesions and lesions in the brain that look like little plaques or little blockages in the brain, and that's actually what sclerosis means. Remember, sclerotic means hardening. So that's why it's called multiple sclerosis. But this is an autoimmune disease. They don't know how it is formed and how people get it. But like I said, it is a massive demyelinating disease of the brain mainly. Onset, when people get it, typical symptoms are going to set in between, this is 15 to 45. That's a pretty broad range. I would say late teens to maybe up to 30 is when people are going to start having showing some of their symptoms for the first time. It is rare for children to get it, but I have seen one person in my life with a little girl with MS, and then it's very rare to be diagnosed over the age of 50. It's predominantly a female disease. We don't know why. It's predominantly female. And for some reason, we don't know why either, Caucasian women are twice as likely to get it as African women. And that includes African Americans and people of African descent from anywhere in the world, that live anywhere in the world. So it's not just people that live in America, it's Black people all around the world. White people are twice as likely to get it. Weird. We don't know why. So it's just some stats. There's approximately right now about between 350 and 400,000 people living in the US with MS, with different degrees and different types of MS. And there is a strange pattern that happens around the globe about MS. So people that live in usually colder latitudes or longitudes or whatever they're called. I think it's latitude. The countries and areas that are closer to the poles, like the northern US, the Scandinavian countries, Northern Europe, Canada, Southern Australia, New Zealand, they're close to the poles. Well, they tend to have a lot more incidences of MS than other regions. You can look at these places that are warmer as we go down the list, and then when you get to Asia and Africa, which are right around the equator, you have barely any people getting it. So we don't really know why that is, but they do think that it must be, besides being an autoimmune component, now they're thinking that it's autoimmune plus something to do with the environment that you live in, but they don't know what that is. Most patients survive about 20 to 25 years after diagnosis, so they live for a pretty good long while. Most of the time they die, death is caused by respiratory infections or UTIs. You can die from a UTI if it gets bad enough and spreads outside of your urinary tract. And respiratory, once they get to the point where they are in power chairs all the time, or they're in bed a lot of the time, That's going to cut down on their breathing efficiency, and then their coughing. They'll lose ab muscles and ab strength as they progress in their disease, and they won't be able to cough up as many secretions, so they'll usually die of pneumonia in that case. This is a list of the most common symptoms. They all experience a lot of fatigue. I mean, 24/7 fatigue. It's not just feeling sleepy or tired like we may have feel if we say we're fatigued. This is just a mind and body fatigue. Gait disturbances, almost all of them. Bowel and bladder problems, the majority. Various neuropathic pains and other sensations that are weird. Visual disturbances, just over half of them. Almost half of them are going to develop cognitive problems throughout the course of their disease, not in the beginning, but as the disease grows on. And usually the cognitive problems are not really that prevalent until at the end of the disease. And some of them are going to have tremors too, and they may look ataxic. Don't look at these numbers here. I don't know where that $1,100 came from, but the lifetime cost says $500,000. That's probably even more, including what you're getting. Just think about if you get diagnosed with MS at the age of 30, and then you're going to live 25 years, well, you're always going to be constantly getting immunoglobulin infusions. You're going to be constantly going to therapy all the time. So $500,000 is not going to last very long. So this is a combination of what your insurance pays plus what you have to pay out of pocket too. And that doesn't include medical equipment like your wheelchairs, any home modifications you have to get done, vehicle modifications, which are common. So there's a lot of money that goes into it. I'll let you read these migration risk factors. It's very strange and it is a little weird, but remember I told you that the places closer to the poles, the North and South Pole, the colder regions of the Earth have you assume more of a risk of getting MS. Well, I don't know who figured this out, and I don't know how scientific this is, but if you are a child and you live in one of those high-risk areas, and then you're under the age of 15, and then you move to a low-risk area, then your body is gonna assume the risk of the new location. But if you're under 15 or if you're over 15 and then you move to a new place, you're gonna keep the risk. You're gonna assume the risk of getting MS of your birthplace. That doesn't make any sense to me, and I don't know why 15 years is the cutoff date, but it has something to do with it. It does have a lot to do with genetic predisposition. There have been some familial tendencies identified, but nothing concrete. And they are looking into different toxins in the environment from pollution to see if that plays a role in it too. Like I said, the etiology is unknown. They do know that it's an autoimmune response, but they think that it could be triggered by a virus or maybe some other kind of environmental trigger like a toxin or pollution. And if those people are genetically susceptible to getting MS, then this virus or these chemicals can go ahead and cause the MS. But sometimes if it's genetic or familial, they're just going to get it anyway. So there's really sometimes no way to know. More theories. I really just said all these. Okay, so what's the mechanism of injury here? Well, the mechanism of injury, it's an asymmetric demyelination of, this is the oligodendrites. Just think of the axons and the neurons of pretty much the whole brain and the dorsal spinal cord. You can pretty much get demyelination anywhere around any of the neurons, any of the axons, and it's going to eat away at the myelin around that. And if you remember, myelin is like the conduction, myelin is like the insulation over an electrical wire. Well, if you take that insulation away, the electricity is not going to go down the wire as efficiently. Same thing with MS. If we don't have myelin on our axons and our neurons, the signals are not going to travel correctly, or they're going to travel and get incorrect information to the body, and it might cause spasticity or something, or weakness, or we may not get the signal at all. But it can happen asymmetrically, and it leaves plaques. It leaves small, what we call a gliosis, which is a plaque, which you can actually see. It's like leaving a little scar on the brain. And those scars also get in the way of neural transmission too. So not just the plaques, but the scars that it leaves behind blocks neural transmissions too. So that's kind of a double whammy. There is no reliable specific test for figuring out if you have MS. It's basically a diagnosis of exclusion. Basically what they do, if you start having weird neurological symptoms, people will go to a doctor, and then the doctor will, hopefully if it's a neurologist or even a PCP, they'll hone in on this is signs of a neurological injury. So they'll wait, they may do a scan to see if there's a plaque yet. And even if there's not a plaque, they're still going to follow you over the next few months in the year. And they're going to see if you have any more episodes of neurological disturbance, or if your neurological impairments that happen, if they progress. If they progress and there's no better explanation for it, like no blood test shows anything, there's no tumors, there's nothing wrong with blood flow, then they give you the diagnosis of MS. So they rule out everything that it possibly could be, and then if you still fit the pattern of MS, then they give you the diagnosis. I'm not going to read this whole slide for you, but you can read it. This just shows what's the word I'm trying to think of? Just shows the familial tendencies. If one family member has MS, the chances of another family member having an MS. You can see that let me see if I can see where it says that. You can see at the top two bullets, if the family member has MS, it's 1 in 1,000. If the father has MS and the baby is a boy, it's 1 in 100. But if the mother has MS and the baby is a girl, it's 1 in 50. So you can see that even though women are much more likely to get it, I will show you later that men have worse symptoms than them. So initially you might get some corticospinal tract involvement. So you'll in your lateral and your dorsal columns. So you'll get some spasticity, some paralysis, some stiffness, a little bit of slowness of movement, general weakness. It could be in one part of the body, or it usually is in one part of the body when it starts, and then it tends to spread with progression. And then overall decreased cardiovascular endurance too. You do tend to start to have some incontinence of your bowel and bladder at this time too. You can develop cranial nerve palsies of cranial nerves 3 through 12. So, and that'll be upper motor neuron lesions. So you can have vision problems. That's what ophthalmoplegia means that's actually paralysis of the eye. So you could have where you can't move your eyeballs around. Nystagmus, when your eyes are jumping back and forth. And dysarthria, which when you're having trouble speaking. Vertigo, feeling of the room is spinning. Tinnitus, ringing in the ears. Facial weakness, facial sensory loss. Cerebellar signs, you know all about the cerebellum, so they'll have ataxia, their movements will decompose and they won't be able to do things as well. They'll have dysdiadochokinesia, they'll be hypotonic, some paresis, some generalized weakness, and it'll probably be symmetrical for all four extremities if it's a cerebellar lesion. Cerebral lesions, if the first lesions happen in the cerebral hemispheres, you're going to get a lot of optic neuritis. So you'll get a lot of visual disturbances. This is where you'll start to get some intellectual and emotional changes. If it's more in the frontal and the mid part of your cerebral hemispheres. Seizures tend to happen, hemiparesis, almost like a stroke, hemisensory loss, almost like a stroke, and dysphagia, trouble swallowing. So really, I really already named all these things. These are common motor symptoms of MS: spasticity and reflex spasms, weakness, gait disturbances, major fatigue, major all the time, swallowing and breathing difficulties, and all those things. You can read those. Sensory problems, they tend to have numbness of certain parts of their body, and then they have pain, usually of musculoskeletal origin. So it'll be pain, but it'll be for a good reason. So it might be pain of, like a lot of them will develop low back pain because they're sitting in their power chairs most of the day, or they're developing knee pain because they're not up and walking around all day. Their knees are staying in one position. So that's true musculoskeletal pain. That's really a real pain. They can develop paresthesias where they just have different sensations on, like light touch may be impaired, or sharp and dull may be impaired on different sides of the body. Dysesthesias means bad sensations, so they may have hyper sensations. And paresthesias could go along with distortion of superficial sensations too. It's where they can feel when you're testing them, or they can feel when something's touching them there, but it just doesn't feel quite the same as it used to. Most of them are going to develop visual problems, more so in the as the disease progresses. At first, they'll just have diminished visual acuity. It'll just be, they won't be able to see letters as clearly. They may need to get a new glasses prescription. A lot of times they develop double vision, and they have to have prisms put in their lenses in their glasses to get rid of the double vision. There's special kind of lenses in them that are prism shaped. You would never know by looking at them, but they help get rid of the double vision so they can just see one thing. They develop pain. They can develop ocular pain. If you've ever had a migraine and your eyeballs hurt and they feel like they're about to pop out of your head, they develop that. And sometimes that can just stay all the time. And sometimes they can develop this weird thing called a scotoma. And it's almost like a small blind spot in their eye. And it only happens it'll happen on one side usually. And it can happen anywhere in their visual field. And it can just be a blind dot or a square or just something blacked out where it's just, but they can see all around it, but they just have a blind spot somewhere in that eye. It's kind of weird. That's not to be confused with macular degeneration. Don't confuse it with that. Other common bowel and bladder symptoms, At first, they're going to start off always having to go. They're going to have to go all the time. They're going to have urgency and frequency, and and that's going to lead to incontinence. Eventually, they won't be able to make it to the bathroom. Urinary retention can happen, where their bladder may fill up and not empty, and that can cause some autonomic problems. And constipation is also very common because they're sitting in a chair all day, so gravity is not pulling down on their GI system, so they tend to get constipated. Usually these people have to be cathed intermittently, or they get what we call a suprapubic catheter, which is where the urethra is totally bypassed, and they make a little port under your belly button that goes into your bladder, and the little port sticks out just about this far from your skin. And then whenever you're ready to cath yourself, you have a specific, like a plastic tool that you just stick in the port, and it's a one-way port. So all your bladder will drain out the port, and then when it's empty, when it stopped draining, you pull it out, and then the port closes, and it's the easiest way to cath. And that also cuts down on most UTIs, because you're not going through the urethra, and not going into the bladder with the foreign bodies. Usually, well, you're not going in with a catheter tube, so it's a lot safer to have a suprapubic catheter. Sexual symptoms are always going to be common signs and symptoms. They're going to have diminished genital sensation. Impotence is really common with men. Now they do need to have these symptoms in this part of their life addressed, because sex is an ADL for adults, and we're adults, and if we're married, then we want to be with our partner. So they may do things like medication, or may go through sexual education classes like we used to give at TIER to address different things, because now their sexual life may be different now. Cognitive and emotional symptoms, 75% of people, generally doesn't happen until later in the disease. But if your MS is more cerebral in nature and getting a lot of your frontal lobe in like the middle of your hemisphere, then these can happen a little sooner rather than later. Depression usually hits in right away with everybody, because it's who wants to have a chronic demyelinating progressive disease that they're probably going to die from? Nobody does. So everybody's going to get depressed. They'll be a little emotional and things, and they'll have and as the disease progresses, they may have trouble expressing their emotions and controlling their emotions. So they may have uncontrollable crying sometimes, and sometimes uncontrollable laughter and happiness. Judgment disorders, can't really judge things for safety wise, or judging things if they're a good decision or not. Agnosia means you forget the names of things. So you know what objects are or who people are, but you just don't remember the name. So like I could see my coffee mug sitting here on my desk, and I know what it is, and I know it's had coffee in it, and I know if I pick it up and drink out of it, I'll get coffee, but I can't remember what this thing is called. My brain just can't pick up the name of it. That's what agnosia is. Memory problems, more so with short-term memory, but long-term memory can be affected too. Diminished conceptual thinking, so learning new concepts, or abstract thinking. If you're thinking abstractly or trying to do something, being creative, that's going to be affected greatly. And a big decrease in attention span and concentration. So there are a few different types of MS. There's 4 different main types, and we'll talk about them here. So the first type is called, and we'll start in the order of the least The least serious all the way to the most serious. Now, after I say that, let me tell you that people can move from one stage to the other. Some people do move all the way through the 4 stages. Some people will move to one stage and stop there and then never progress again. But most of the time, people will keep one stage, but sometimes they change. The first type is called relapsing remitting. Okay, so see the word relapsing, it goes away and comes back. So when you get this, you have about 1 or 2 sudden onset attacks, and that's what exacerbations mean, with complete or almost complete recovery of all your impairments that it gave you. And then you're going to have long periods between those exacerbations or attacks. That's about 20% of people with MS. Okay, so they have just 1 or 2 attacks here and there over the years, and they either completely recover or they almost completely recover. So they might be left partially weak or partial gait deviations, but they're pretty good. This is the category that most MS patients are put in when they're first diagnosed, because remember that they're tested for everything else before they're given the MS diagnosis. The next type is called secondary progressive. This is similar to relapsing remitting, but the person is going to have more attacks and exacerbations, and they're going to have shorter intermissions or breaks in between those exacerbations. And often their physical declines and impairments are irreversible. Not all the time, but often. And this is about 20 to 30% of people with MS. Give me 1 second. Let me stop sharing for a second. Okay, we're recording again. Sorry, I had to go answer a question for somebody in lab. We're back now, and we're almost done. So let's see. We just got done with secondary progressive. So we went through relapsing remitting, secondary progressive, primary progressive. Okay, is the next one. This is similar to secondary progressive, but you have incomplete recovery from your attacks with progressive impairments. You don't have those discrete exacerbations or attacks like other types of MS do. You're basically always slowly declining through your whole life. So it's a steady and progressive decline and loss of all function. That's primary progressive. Progressive relapsing is the next type. It's similar to primary progressive, but you do still have occasional acute attacks. So it's almost like you have the bad primary progressive where you're always declining, but now in progressive relapsing, you have that same progressive decline, but now you have attacks and exacerbations on top of that. So you're going to decline a lot faster. It's a very fast decline with no recovery of losses, and that's only about 5%, the bottom 5% of MS patients. This is the worst type. Well, these and this is the worst type. Like I said, patients can move from one type of MS to the next. And I would say that the majority of them do move from one stage or from relapsing remitting to the next one. They don't have to necessarily go through all 4 stages, but they're always being checked by their neurologist. So they're always being kept up to date with and their attacks and everything. So they follow them and keep them in the right category. Don't worry about that. These are just precipitating factors of decline. Sometimes people, before they start having MS, they'll say, oh, I had the flu, or I had the cold, or I had a UTI, and then it went away, and then I just started noticing some of these symptoms. Pregnancy is a risk factor for some reason. if you have it, if you are not to get MS, but if you have MS and then you become pregnant, and you can have MS and carry a baby to full term, but it can cause some problems in your exacerbations. Transient deterioration, you're going to be very, very, very adversely reacting to heat. They're not going to like the heat. So they're going to be very, very fatigued, and they're going to be really, really, really wiped out by heat and exercise. So we have to exercise them moderately in a cool environment and make sure they don't overheat themselves, and drink plenty of water too. Stress can cause more exacerbations. If we exercise them to exhaustion, or if they exercise to exhaustion, that can cause an attack to occur in their brain. Dehydration can cause it, malnutrition, and even sleep deprivation can cause it to happen too. So all of these things can cause your impairments to just get worse, especially the heat and overexercise. Predictors of a good outcome, well, if you're female, that's automatically a good sign. If your initial onset was with only one symptom, that's a strong indicator of a good outcome. If you have complete or almost complete recovery after your exacerbations and attacks, that's a very good predictor of a good outcome lifelong. And if you are diagnosed before the age of 35, you usually have a better outcome too. Predictors of bad outcomes. If you have one of the progressive types, it's just you're always going downhill. If you're male with MS, that's automatically a predictor of a bad outcome. It is. If you are diagnosed after 35, I don't know what it is about that 35-year cutoff, but after 35 can be a predictor of a bad outcome. If you have, at 5 years after diagnosis, if you have what we call pyramidal and cerebellar signs like nystagmus, tremor, ataxia, and dysarthria, if you have those after 5 years of being diagnosed, that's a bad outcome predictor. And if you just have a high frequency of attacks, that's a really, really bad outcome, as you could probably imagine. These are some of the medications that they give them. They're immune response drugs. So they're all, you can just remember them as interferons. And there's a few more out there now. And they usually have to get these done in infusions. PT examination is going to cover everything that you would cover for any other neuro patient. You might want to spend a little bit more time looking at their cardiovascular endurance and their respiratory status. You might want to spend a bit more time looking at their bed mobility and transfers. And their ADLs. Yes, we're still going to do strength, range of motion, balance training, ambulation, and coordination training, but we've got to get a good idea of what their cardiovascular response to exercise is going to be like, and also how quickly they fatigue, because we can't exercise these people to fatigue. But other than that, we're going to do all the same stuff, but you're probably going to be taking a lot of rest breaks with MS people, and that's okay because that's just their disease. These are some of the different MS examination tools that are out there. The MS impairment scale is a real popular one. The Hon-Yar, what is the name? The Hon-Yar, it's either Hon-Yar or Yar-Han scale is probably the most popular one used by neurologists to get to track somebody's progression of their disease. Remember that overly aggressive treatment sessions can cause an exacerbation. So we have to give lots of rest breaks. We don't want to we don't want to cause new complications by overloading them so much that we cause them to have an impairment again. So a lot of what we're doing is we can get them to get some of their impairments reversed, but the biggest thing we're going to be doing is keep them as independent and maintain their optimal function as long as humanly possible. So to keep them going as long as possible. So if that means that they have to go from walking with a walker to a power chair, that's fine. And let me tell you that you probably won't see many MS patients in manual chairs because they're so sensitive to fatigue. They would fatigue out just pushing themselves down a hall. So they almost always go into power chairs. And it changes their life, and it allows them to still work. It allows them to still drive up into a modified van and be able to drive. It allows them to go out to the community and things like that, to where otherwise they wouldn't be able to get themselves out. The medical treatment and the physical therapy treatment that we're giving is never going to alter the course of the underlying disease of MS. Don't think anything we're doing is getting them better. We're just we're working on their impairments, and we're keeping them as functional and independent as possible, as long as possible. But there's nothing we can do about the disease itself yet. Medicine's still working, the medical science is still working on this, and hopefully one day we'll have a cure or no more. But right now we just don't know about it. These are some of the short-term goals that you might see on a plan of care, and they might be stuff that you would probably already think of: increasing range of motion, overall strength, endurance, and their functional mobility. We might have to help with their ADLs a little bit. We might have to teach some compensatory techniques for energy conservation. So if you're working on ADLs a lot, you might be co-treating with OT a lot. Educating them on skin care so they don't get pressure injuries. Educating them on activity tolerance to keep it low and to keep it at a lower level, not to go too hard on themselves. And lots of family and patient education too. Long-term goals, we want to maximize, almost like I just said, what I've been saying, you want to maximize functional status and independence as long as humanly possible. Prevent secondary impairment, so prevent contractures, so make sure you've got a good range of motion program. You may need positioning devices, maybe they need orthotics if they're doing standing programs or gait training, get them the kind of orthotics they need. Any kind of assistive device like walkers, canes, power chairs, they all need that. We want them to maintain their employment status as long as possible too, because they need to be a part of the community, because at first the majority of MS patients just have physical symptoms for most of their life. Their cognitive symptoms haven't come on yet, and some of them will never get cognitive symptoms. So we need to keep them working as long as possible. And I know two people that are past patients of mine from years ago, and one works for Exxon, and she can only move her right arm, but she's in a power chair, but she works full time. She's like an executive secretary for one of the presidents. She does all her typing and memos and everything by voice, and voice translation. Her computer screen tracks her eyes, and that's how the mouse knows to move. She's got all this stuff set up, and she can only move one arm. Then I know another man with MS who was a geologist, and he was a patient of mine. Now, he's not quite as bad as her. He had just went into a power chair when I first started meeting him, but we were working on just gait training and balance and stuff with him. but he still worked every day, and he still worked as a geologist every day. So they work there, and as far as I know, they're still working, but there will be a time when limitations will happen and you'll just have to stop. Nothing new here. These are old wives' tales that they used to say that could help in MS symptoms, and these are all debunked now, so I'm not even going to say them. Assistive devices. So they're going to need assistive devices to help them maintain their independence as long as possible. So AFO stands for ankle foot orthosis. This is an orthotic, and we'll talk about it more next semester. But this is just an ankle brace. Or you can have a KAFO, which is a knee ankle brace, which can keep their legs stable. Gait assistive devices like canes, crutches, walkers, wheelchairs, power chairs. For ADL equipment, they may need reachers, things like for bathing, for dressing. They may need special built-up utensils where the handles are thicker and easier to hold on to. We always tell them to keep their cell phone on their body at all times in case they have a medical emergency or in case something happens and they're alone. They can always call 911 or call somebody. Or if they have one of those life alert systems, they can just push the button. But we always say, since cell phones have come out, people are always telling people to keep your cell phone on you at all times. Or if anything, keep that button around your neck. And that would be all for MS. So that might have been quick and dirty. But if you have any questions about it, you can email me. I do have several video links on course content for you to look at that show mechanisms of injury, kind of shows an inside of the brain, animations of MS and how it happens. So I would like you to look at those too. Maybe help you clear some of the cobwebs up. Okay, thank you very much.